So, let me start with a warning. There will be no rocket science in this talk, but however, it could help you improve patient care and even save some lives. My name's Robbie Foy. I'm a GP at Fieldhead Surgery and Professor of Primary Care in Leeds. I'm going to share with you an example of some work we've been doing and also give you a quick tour of a website that we've developed. As you know already, opioids are commonly prescribed for chronic non-cancer pain, but this is despite little evidence of their benefit, and in fact, there's accumulating evidence of their harms, including addiction, overdoses, falls, fractures, and even death. NICE now routinely recommends against using opioids for chronic pain, but a few years ago, before this, we did a study with practices in Leeds and Bradford where we documented rising trends in opioid prescribing. Indeed, opioid prescribing rose sixfold for stronger opioids, and there was a tenfold variation in opioid prescribing between practices. Now, people often say, well, a lot of these variations might be because of patient demographics or socioeconomic differences, but actually our work showed that a lot of the differences are down to us, not our patients. So, in response to this, we worked with the CCGs to develop a feedback campaign whereby we gave bi-monthly feedback to general practices over a year. The campaign reached about 316 practices and included comparative feedback. And we also did some stuff where we included behaviour change techniques. So we used persuasive messaging, non-judgmental prompts to ask people to think twice before prescribing opioids and actively review all those getting repeat prescriptions. We also highlighted and allowed practices to find groups of patients who might be at higher risk of dose escalation based on our previous work or of long-term prescribing. The other thing about the way we measured this is that we took out patients already prescribed opioids for who had cancer diagnoses. And we also encouraged practices to come up with practical action plans and what they were going to do. So, did this help? Well, I did lie earlier when I said there'd be no rocket science. Actually, we did something called a controlled time series analysis, whereby we looked at trends in practices who got our feedback campaign and then compared them with a control group of practices from across the rest of Yorkshire to see if we'd bucked those trends. And the answer is that yes, we did buck those trends. This graph here shows, the dotted lines show the rising trends in the control group of practices before, during and after our feedback campaign. So you can see that opioid prescribing was still rising, whereby the continuous black straight line, that shows that after the practices started getting the feedback, prescribing fell. And even after the campaign, it continued to fall, but at a lower rate. So we estimated from this campaign that over the course of a year, about 15,000 fewer people were prescribed opioids. We also found that we'd estimated about £1 million nearly saved in direct prescribing costs. And that we were particularly effective at reducing prescribing in the over 75s who are at higher risk of falls and death. We didn't find any evidence of a compensatory rise in, for example, NSAID prescribing, which actually fell during the campaign, and we didn't find any evidence of an increase in referrals. Afterwards, we interviewed practices and found that the campaign was well received and didn't seem to harm relationships of patients. So since then, the campaign has been scaled up across Yorkshire and Humber and the northeast of England and now reaches around 1,000 practices. And we also tackle gabapentinoid prescribing and antibiotic prescribing. Our approach is about being realistic within what can be achieved in the normal everyday constraints of general practice, so it's not evangelical. We never said never prescribe opioids. We trusted you to be professional and to use your own judgment in prescribing. So give yourselves a pat on the back. So would it be useful at all to have a locally developed website which is evidence-based and offers practical advice on how to make a change in practice? So if you Google West Yorkshire Research and Development and then click on implementation in the top right-hand corner, you'll find one that we prepared earlier. So this is a website which is based on the Aspire research programme, Action to Support Practices Implementing Research Evidence, which brought together the CCGs, patients, NICE, and involved over 200 practices. We then took some findings from that and lessons from that programme. We did some user testing in developing a website with GPs. And then we've produced this website, which in a way is mainly aimed at groups of practices aiming to achieve change, but some of it will also be useful for single general practices. The first rule of this website is that there's no rules on how to use it, except just feel free to browse about. So, for example, you can go from looking at 10 top tips on quality improvement through to how to do clinical audit, and also select approaches to help change practice. Each section, or most sections, contain some advice on what skills and resources you're likely to need, what the likely time commitment is, some do's and don'ts, and some examples from other work. So, feel free to spend a few minutes browsing our website. You can easily do so, according to the Daily Mail, when you're sitting with your feet up, avoiding seeing patients during the pandemic. We'd love to get any feedback on the website, good or bad, to help us improve it in the future. So remember, small changes, one patient, one consultation at a time, add up to make a big difference. And that's what makes general practice such a major force for quality improvement and improving population health. So, thank you for your time and thank you for your improvement efforts.